Well, it's 12:30 and I see participants accumulating for this 10th in our series of first lectures. I want to extend a warm welcome to everyone from first years through faculty to this year's first lecture. My name is Dina Rifkin. I'm one of the faculty advisors for the amazing second year medical students who have organized this event. Without delaying us any further, I'd like to announce, to recognize the two members of the first lecture committee who are going to be leading today's session, Sophia Shao and Divya Prajpati, and turn the stage over to Sophia, who's going to introduce the first lecture today.
All right, so hello everyone. Again, I'm Sophia. I'm a second year medical student right now. And I just wanted to first thank all of you guys for taking time out of your afternoons to be here with us today. For those of you who are joining us for the first time, especially our first years, again, welcome. And just a little bit about what we do as a committee. The first lecture is an event organized every year by us, a committee of medical students here at UC San Diego. And so each year we have the honor of choosing a piece of literature that we believe provides perspectives on the medical field that is integral to our medical education. And for this year, our 10th year, we have an especially unique and exciting program for you all in also a kind of different non-live or non-in-person format. But the book that we have chosen as a must-read for all of our preclinical students is the New York Times #1 best-selling Pulitzer-nominated memoir, When Breath Becomes Air, by the neurosurgeon Paul Kalanithi. And speaking on his behalf, we are so lucky to have his widow and the author of his epilogue, Dr. Lucy Kalanithi, who is an incredible physician, writer, and speaker in her own right. So since it may have been, anywhere from maybe a few hours to a few days to a few years since some of us have last picked this book up, we have included a quick trailer to provide a little bit of recap for everyone and just set the tone. So I'm going to share my screen now and play that really quickly. Sorry guys, it seems like there is no sound, so let me see if I can figure that one out.
Yeah, when you go back to the share screen, there's a little checkbox down at the bottom.
Okay.
It says share computer sound.
So share
stop
screen.
sharing.
Oh, okay.
Stop sharing.
Okay, let's try that again.
So stop sharing.
Okay. Sorry, guys.
Share screen, and there's a checkbox down at the bottom of that screen.
Got it. Okay, let's try this again. Can everyone hear?
5 years down the line, I don't know what I'll be doing. I may be dead, I may not be. If you asked me when I was 17 what I'd be doing with my life, I would have said, oh, I'd definitely be a writer. But found medicine was, in fact, the perfect place. I first began noticing symptoms in my 6th year of residency. Obviously, Lucy and I were both very suspicious that I had some form of cancer, but actually having the confirmation was still devastating. Since Katie's birth, my time with her has had a very peculiar and free nature. In all probability, I won't live long enough for her to remember me. And so the time just is what it is. it's a careful balance. If you don't think about the bad case, that ending is going to be very rough on you and your family. But if you don't think about the good case, you're going to miss an opportunity to really make the most out of your life and time.
All right, so that was honestly very beautiful and moving. And I hope you guys, enjoyed that as much as I did. But without further ado, I would like to introduce our speaker today, Dr. Lucy Kalanithi. So Dr. Kalanithi is a clinical associate professor of medicine at Stanford University and an advocate for culture change around healthcare value with particular interests in serious illness care, clinician wellness, family caregiving, and narrative medicine. A graduate of the Yale School of Medicine, the University of California, San Francisco's Internal Medicine Residency, and a postdoctoral fellowship at Stanford's Clinical Excellence Research Center. Dr. Kalanithi is a fellow of the American College of Physicians, a member of the Alpha Omega Alpha National Medical Honor Society, and an honoree of the Mass General Cancer Center's The 100. She has implemented novel healthcare delivery models in primary care, hospitals, and health systems, and she has appeared on stage at TED-Med, on NPR, PBS NewsHour, and Yahoo News with Katie Couric, and in the Washington Post, the Wall Street Journal, Elle, and the New York Times. Her new podcast, Gravity, explores narratives of suffering and is in development. Dr. Kalanithi lives in San Francisco Bay Area right now with her daughter, Katie, who is a first grader. So it is my complete honor and pleasure to welcome Dr. Lucy Kalanithi to our figurative stage today.
Hi, so nice to see your face, and hi everybody, I'm so glad to be here.
So again, thank you so much, Dr. Kalanithi, for being with us today. And before we get started, I just wanted to provide a quick little summary of how this afternoon is going to go. So the first half of today's talk is going to be in a fireside chat format where we have a pre-prepared set of questions that I will be posing to Dr. Kalanithi surrounding certain topics and themes that our committee believes to be central to this book about what it means to be a doctor. And the second half of today's talk will be turned over to you guys, the audience, and it will be led by Divya, and it'll be dedicated to answering questions. So please utilize the Q&A function of this webinar in order to post any questions or comments that you may have for Dr. Kalanithi over the course of this talk. And then at the end of our pre-existing question section, Divya will be posing those questions to Dr. Kalanithi on your behalf. In addition, we also have another forum, and there's a link to that sent in the email that you all got as well. It's the Kudo board, and if you don't have a chance, or if you don't want to use the Q&A section to add questions, or if your questions or comments don't end up getting addressed during this session, we will be sending the Kudo board and all of the comments and questions and pictures or whatever that you guys want to post on that to Dr. Kalanithi afterwards. So if you have anything else to say and you don't want to say it here, or you don't get to say it here, please use the Kudo board as well. And then after the Q&A, we will also be holding a more informal virtual reception as well, and there will be a separate Zoom link for that. And this will be, a more informal setting for you all to get a chance to chat with Dr. Kalanithi, and it will occur right after our main session ends. So keep an eye out for that Zoom link if you are interested in attending afterwards. So again, without any more logistical stuff, I'm going to get started on the questions that we have prepared. So before we get into the really meaty stuff about what it means to be a doctor and all of that, I would love to learn a little bit more about what Paul was like. So from When Breath Becomes Air, we get a pretty good sense of how Paul describes himself and his passions So, we learned that he has this really deep love of literature and English, and we learned that he loves learning about how the brain works and how the mind kind of interacts with the brain and what that relationship is. And, he tells us that he's a little bit of a prankster. He loves a good whiskey. But is there anything that you would want us to know about him that he perhaps didn't highlight so much when he was writing this memoir?
Sure. And I also just want to say, thank you so much for having me. It's such a honor to be here and to be here representing Paul as well, and to participate in this moment in medicine with you and this moment in your careers with you. So thanks for having me and congratulations. I'm thrilled to be here. So the one thing I would add about Paul was his sense of humor, which shows up a little bit. And I made mention of this in the epilogue to the book, and I was like, I need to put a mention of Paul's sense of humor. And the editor said, well, you don't want the reader to know what they're missing. And I was like, yes, I do. And so when we started medical school together in 2003 and met there. And initially when I saw Paul, I was sort of like, oh, there's this sort of cerebral literary guy in our class. And he ended up running a bioethics seminar kind of as his side hustle as a first-year medical student. And then I just sort of knew he was a smart guy, and then realized in short order that on his medical student ID, when he stepped up to get the ID photo taken, he put on a fake mustache in the photo. And it was like very obviously fake, but also sort of a private prank. He hadn't told anybody he was going to do it, and it ended up on the school face sheet that everybody could see for 4 years. And so that was when I sort of realized, that was when I became really interested in Paul, was like, he was immensely reverent, as you can tell, very serious about being a physician, very, cerebral and literate. And then at the same time, he was very irreverent and funny, and sort of this, sort of demonstrative of this desire to like live life in the fullest way in whatever domain. So I really love that about him. And for what it's worth, I think something like 10% of our class of medical students ended up partnered with each other, like falling in love with someone in the class. And so it makes me think about, like, for some of you, your future partners on the Zoom call, and you haven't even met them yet. So maybe that's true for you guys too.
So everyone who's listening, keep an eye out for the
That's
other
right.
audience members.
Congratulations.
Yeah. Hope to be at your wedding in, maybe 10, 15 years. All right. So moving on. So one of the required courses we have here at UC San Diego is titled The Practice of Medicine. And ultimately the goal with this class is to teach us how to be a doctor in ways beyond just like learning the science and the pathology of, illness. And we get a chance to do things like practice empathy with simulated patients. And then we get to learn in a classroom setting how to have difficult conversations with patients, among other things. And so learning how to empathize with our patients in a classroom setting is obviously very different from interacting with them in a clinic. And it's also very different from being, a patient yourself. So Paul obviously went through this entire journey of, going from medical student to physician to patient towards the end of his life. And so what was it like for Paul in this kind of transition through different roles? And were there certain things that he felt that being a physician himself prepared him for this transition? And then were there other things that just completely threw him off when he made this kind of role shift almost,
Yeah. So that's interesting that you say role shift, because that's the way he experienced it. He writes in the beginning of the memoir, as you know, about that distinct transition in a flash from being a physician to a patient, where he takes off the scrubs and puts on the patient gown and goes into the room, and then is looking at his own scan and seeing his own body failing on the screen. And then he says something like, the future I had imagined, the one just about to be realized, evaporated. And I think that really is what it felt like. And there's the challenge of facing your mortality and realizing that to have an incurable illness is life limiting, right? It limits the amount of time you have. But I think I hadn't quite realized that in addition to the pain of facing mortality and the pain of facing uncertainty as well, the major upheaval in identity was so striking. And it sort of made me realize for all of us how much of your current identity is tied up in a future conception of yourself and who you imagine you will become. And, in marrying someone and picturing decades together, or having a child and picturing a life forward through adulthood with that person, or starting off on medical training, your future self reflects back onto the present you. And I think he was, the same person he was 5 minutes before, and he was also a totally different person living in a totally different world and needing to reconceive of who he was. I reread Paul's book in preparation to talk with you all, and saw it with fresh eyes in some ways, because I haven't memorized, but I also haven't read it in 2 years. And so, or something like that, partly because I feel like I know it so well. But it was really interesting to read it for a lot of reasons. And one was I circled all the times he said identity. I couldn't believe how many times he said the word identity. And I feel like that was a huge part of grappling with illness. And I think in answer to your question of how did being a physician prepare him to become a patient, he was surprised at how little it prepared him for that existential upheaval. And I think he had a sense of that immediately, because when he received that terrible chest x-ray result that showed that his lungs were full of nodules and it likely meant cancer to both of us, we packed up to go to the hospital for his workup. And we were packing things like phone chargers and socks and a pillow and stuff and an insurance card. But he also packed books. So he took this stack of books with him. Actually, a bunch of them are up. 3 of them, the most important ones, are Being in Time by Heidegger, which is right there. That's like his copy that I have and love. And a novel called Cancer Ward by Solzhenitsyn, and Mere Christianity by C.S. Lewis. And so it was sort of this, triad of religion, philosophy, and literature. And those books sat on that little rolling side table that patients all have in the hospital, with like the pink water jug and a couple of other things, remote control to the TV. And I think Paul had a sense that it was not medical knowledge that would help him make sense of this. And instead it was being linked to all human beings across time who have suffered. And then I think being a physician certainly helped in many practical ways, and in understanding the limitations of prognostication, and also the probable truth of how little time he had left, which helped us make decisions about what he wanted to be doing with his time, whether we wanted to have a child. But I think ultimately the thing that was the biggest salve overall was rediscovering or reshaping a purpose. And I found that the time that Paul went through that was by far the hardest was when he felt like his neurosurgical aspirations were dissolving, and there was sort of a vacuum in their place. And so making the decision to have a child and forging this new identity as a writer, Nietzsche says, he who has a why to live can bear almost any how, which I think about a lot. It's like Maslow's hierarchy turned upside down. It's like if you have almost nothing, but you have purpose, it's very sustaining. And so that made me think a lot about how to support loved ones and patients and others who are going through that same type of upheaval where their bodies, the frailty of their body sort of reshapes their ability to interact with the world, or their need to do it in a new way.
Mm-hmm. Yeah, that's something that, I've definitely thought about a lot myself too. Sometimes, like books and other forms of art and pieces that don't necessarily relate very stringently or to the letter of, you know, what medicine is can sometimes provide a lot of purpose and reason for going on. And it's really beautiful that, you know, he made this full circle of, he started with this love of literature, and at the end of the day, that's also what almost saved him in a way. And so the next question I have for you is, you were obviously with Paul throughout this entire journey that he had. And so what was one of the most frustrating moments for you as you navigated the healthcare system with Paul? And then were there any moments where, you know, you really felt like you and Paul were both being heard in a way that you almost didn't anticipate, or in a way that really felt, you know, really, really poignant? And has any of that changed the way you interact with your own patients?
Yeah. So those two questions you just asked are two sides of the same coin for me. The thing I'll describe that was the most frustrating and difficult was about a moment of not feeling heard, actually. So maybe I'll answer your second question first, which was sort of what was good or what felt connecting when Paul was a patient and I was there as a family caregiver. I think, you know, that experience deepened for me my understanding of a physician's role or a clinician's role, which was for Paul, foremost, recognizing his personhood, which sounds so obvious, which sounds so obvious as to almost not need to be said, right? But I think when you're a patient and you're one of many, and particularly when you're in the hospital, you're almost literally naked. You, you know, are a medical record number as much as you are a name. You're an electronic chart as much as you are a person. I think having somebody connect to you as a person, as an agent, as someone who has a full life outside the hospital walls is very, very sustaining and important. And I think Paul's oncologists and that team and the palliative care team were very able to do that in a way that was wonderful. And Paul talks about how almost immediately his oncologist made an effort to tailor his chemotherapy treatment to preserve his hands to be able to operate, to reduce the risk of peripheral neuropathy such that he wouldn't have numbness in his fingers or be unable to use his fingers in as delicate a way. And so she immediately took into account the fact of his being a neurosurgeon. And later on down the line, I don't think he mentions this in the book, but he went on a stimulant medication that was a little bit similar to like Ritalin, to help him focus on writing, which was off-label. It wasn't what that medication was for, but he and his doctors chose for him to take it so that he could keep writing. That would be another example. And then I think his physicians also gave a real nod to the existential landmarks of what he was going through. As you know from the book, he went each time hungry for this thing he calls oracular wisdom, where you know, I hadn't quite realized how truly vulnerable he would feel, and how going to see the doctor became, was about so much more than just the technicalities of illness. And then with regard to empathy, I particularly remember one moment with Paul's nurse practitioner where he received or she reiterated the news of the cancer progressing again, which is really difficult. It's almost like a new devastation when you get sick with cancer and then you're doing fine and then you get sick again. It's really hard. And she said something to him like, I really wanted you to be the guy on Tarsiva for 7 years and you are not that guy. And I am so sorry. And she said it like that, where she was bringing herself into it and she was clearly sad and she was reflecting how we were feeling. And I think she was feeling it and present in it. And she was also doing what you just described, which is in this course that you're describing, where you actually literally learn the nuts and bolts of expressing empathy, right? Because I think the flip side of feeling deep empathy is that just because you're feeling it doesn't mean that you will know exactly the right words to say or know how to guide somebody from their feeling to the next step of making a decision or the next step of being able to hear what you're saying. And so I think you know, as you're going through your training as a student, I think some people are like, oh, that's the fuzzy wuzzy class, or we have to do this little side thing, you know, until we can get back to the real work. But I think now as a practicing physician, when I look back on the courses like that, where we learned skills like that, that is a huge part of the real work of being a clinician. And I'll just mention one piece of that. Sorry, this is like such a long answer, but there's one thing I wanted to mention that I find so fascinating is the connection between the physician and the patient is literally part of the treatment. Like you yourself are a part of the medicine for your patient. And what I mean by that, here's some examples. There was a really neat study done at Stanford, I think by a health psychologist who invited patients who knew they were in a study, and they injected histamine into their arm so that they got, you know, like an itchy red area on their arm. And then you know, model clinician came in and rubbed a cream on that area, and it was an inert cream. It was nothing. It was Vaseline or something. And they varied the seeming competence of that provider, and they varied the seeming warmth. So either the person being highly competent, but they weren't really looking you in the eye, or vice versa, or they had it all right, or they looked like they didn't care and they weren't even competent. And then that clinician said, this is really going to help. This rash is going to subside in just a minute. And for the patients for whom the person seemed most warm and most competent, the rash literally did subside, which is so interesting. And I'm sure that only works with certain things in medicine or neuroendocrine processes or whatever, but it certainly can make a difference too on things like medication adherence, whether a patient follows up. There was a study in Oakland of Black men who had a Black doctor, and they were more likely to get preventive services from that physician, which is such a big deal related to trust and representation. And so I think that, I guess maybe I'll just stop there on that point. And now I can flip to the challenging experience that we had, which, so Paul describes in the book what this moment was when he was admitted with chemo complications to the hospital, and one of his chemo medications, a chemo pill, was left off the inpatient medication list. And the resident who was on overnight said, your liver function tests are off, and I took it off for a safety reason. And Paul said, you know, I'm going to have really severe pain if, you know, I have a withdrawal syndrome from this medication that I've had before. And it makes my bony metastases flare and become inflamed and become 10 out of 10 pain. And then the resident says, if you weren't you, we wouldn't even be having this conversation. I'd make you prove it. I'd make you prove you had all the pain. And it was so shocking. And in retrospect, I realized this poor resident must have actually been really burned out and been feeling depersonalized himself, and probably was at the end of his rope. But I wasn't thinking about how that guy's day was going. I was thinking about Paul. And that was probably one of the hardest parts of being a patient for Paul. There's our cat going behind me. And the one thing that Paul didn't write in the book, and I'm not sure why, I think maybe he forgot, because to me, this is a really critical piece of that story. I had the medication in my purse. So I had a pill bottle where I carried, you know, some pain medications and anti-inflammatories and anti-nausea pill and a couple of the chemo pills. I was like, what if we get stranded somewhere? We're going to need this. And so I had it in my purse, and he took the medication out of my purse at 5 in the morning and swallowed it. And then later it got sorted out on rounds when his oncologist came and the medication went back on his list. But I think when I reflect on that as a physician, if I had been the inpatient attending physician or resident or medical student, it's sort of considered a safety issue for your patient to be taking, it's called their home med. His wife had the home med in their purse, and he took it. And but on the other side of that encounter, it seems so starkly obvious to me that a hospital is not a prison. You are there. You are a grown person weighing the effects of this whole thing on your body and your values and your life. And seems really obvious to take that medication that morning. But it was very humbling for me as a physician to go through that and then make that realization for myself about how I would have felt on the other side too. And so I think my own practice, this whole experience, I think, didn't change, but certainly deepened my own commitment to trying to act in service of what will promote my patient being able to live life in the way that they want to. And I think the super simple example, so I work actually, so just to share what I do now, after residency in internal medicine, I did primary care for a number of years, and then I did a postdoc studying healthcare value. And then I now work at Stanford as an educator and working in urgent care clinic. So I see patients in urgent care settings where they're there for one problem and I have to establish trust quickly, and then we have to make a decision quickly about something that's happening that day. And so one of the things that comes up is patients who come in who have a cough, this is pre-COVID, who are worried that they need an antibiotic for their cough. And it's like one of the truisms in primary care and urgent care is like, you almost never need an antibiotic, literally 95 times out of 100. But it's a discussion that I think I used to handle with something like, well, here are the downsides of antibiotics. So you don't want drug resistance, and you don't want diarrhea, and you don't want this, you don't want that. And so no, I don't think we should do it. And you don't need it. And I think now I approach it a different way and I say, what are you hoping for from the antibiotic? And people can answer that question, right? Like, I really want to feel better soon. I have a young baby at home and it's like, I can't take care of a toddler feeling like this. Or I have to give a presentation at work tomorrow, or I'm really scared I have pneumonia. My sister was hospitalized with pneumonia last year. And I think then we can start a conversation around what that issue is. And I can say, oh, you know what, the antibiotic will not help with that, but here's what will. And then it totally reshifts the way we're talking. It's much more effective. It takes less time. It's more satisfying and important. And then I think currently during COVID, I treat COVID patients at Stanford, which is, we have a whole program that's mostly by video, but then oftentimes we're bringing patients in to triage them and make sure that they don't need to be in the hospital. So I am at Stanford treating outpatients who currently have COVID, who are recovering from COVID and don't need hospitalization or don't yet need it. But the thing that is so striking about COVID, even on top of the loneliness of COVID, of being isolated in our homes, and then if you have COVID, knowing that you are literally isolated on purpose, is having COVID is really existentially distressing. Even if you're fine and even if you turn out to be fine, it's like getting a life-limiting illness from one day to the next and not knowing how severe it could get. And it's also kind of a stigmatizing illness. Like, people returning to work after COVID are having a hard time, et cetera. And then there's a lot of practical considerations that are really difficult. Can you isolate from your family? Who can drive you to the clinic, et cetera? But I think being schooled in thinking about existential suffering during the time of COVID has been surprisingly relevant. It comes up almost every time. Like, people are alone and thinking about their mortality, even if they never have before. And it's yielding different new conversations, right? Among families or people who prepare an advance directive, even though they never have. But, it's there's fewer silver linings than not, I think, obviously.
It's also interesting when you said that, you had this like little home kit of medications for Paul, like, for a rainy day if you guys were stranded somewhere. Yeah. I assume you hadn't thought that it would be in the hospital where all of these medications were, right, actually available, that you would be using this.
Right, that we'd be stranded, totally.
So thank you so much for your answer. It was very, detailed and very complete. So I really appreciate it. And so the next one I have for you is about mortality. So I guess that's a pretty good segue, since we've just been talking about, COVID patients and how they've been, dealing more with thinking about their own mortality. So how has your perception of mortality changed from, pre-medical school to medical school, and then through, the rest of your life involving Paul's illness, and then also up to now?
Yeah, so I think my training in medicine informed my own relationship with hardship or mortality, certainly. And then my grieving reflected back into that, and vice versa. I think my own experience training as a medical student, I remember being very struck by being in my early 20s and entering medical school and feeling suddenly, particularly as a third and fourth year, of course, and then as a resident, feeling the burden of the suffering that I was witnessing across all different domains and ways that human beings can suffer. And sometimes that it felt like a weight that I couldn't bear. I have a twin sister who's a writer and who's a lifestyle blogger, who's sort of, whole point of being a lifestyle blogger is presenting like this version of a perfect life, right? Which she doesn't have, and she's written about hardship that she's been through too. But I remember thinking like, oh my gosh, my twin sister is like never gonna see these things that I'm seeing, and this is hard to witness. And at the same time, I feel like being a physician is this amazing chance to have a front row seat to what it means to be a human being and really participate in the fullness of people's lives, right, from birth to death. And so I think by the time Paul was diagnosed with a serious illness, terminal illness, when we were in our early 30s, I think it felt less like something. I think a lot of people sort of approached us and said like, oh, this is so unfair. Like, isn't this just so unfair? And by that time, I sort of had reached the conclusion that that kind of illness from a sporadic mutation is sort of orthogonal to fairness, right? It's something that can just happen. And I think that understanding, of course, came out of having witnessed many, many seemingly unfair things happen to many, many families. I guess one other thing I'll say is I went through an episode of depression in residency and, developed a number of coping skills that helped me through that, including like exercise and sleep and making sure I maintain social connection and developing a meditation practice. And I feel like one of the skills that came out of that meditation practice is paying a lot of attention to all the way that all of us have this automatic tendency to judge or to judge or make an assessment of something in a way that doesn't necessarily reveal the truth. And I think my own relationship to words in describing hardship, particularly in my own life, have changed. So to give an example, previously I'm going through a hard thing, I might have said something like, this is such a nightmare. And I think now I would say something like, this is very painful. And those are two different ways of framing something. And I think, thinking about the fact of our own mortality, I kind of think of with a sense of acceptance or even lightness that I think I didn't have previously. And then I think, maybe I'll just stop there. Oh, one thing I'll say is, I think it's like an interesting, I'll just say the taboos about mortality, like euphemized language or not wanting to talk about it, or being fearful of talking about it or trying to protect each other so not talking about it. Those same taboos or, commonplace ways of communicating follow people right into the hospital and follow physicians right into the hospital. And so I think part of our training is unlearning the taboo about talking about this and learning how to enter into talking about this for real with people. And it's kind of an interesting moment in modern culture where dying and suffering and aging are invisible in some ways in society, and disability, or invisibilized in society. And it's sort of a really strange moment, because I think across human history that has not been possible, or that has not been desirable to do that. And so when Paul's book was first coming out, I was talking to his agent and said, you know, like, his book's coming out and how do you think it's going to do? And she said, well, it's either going to do terribly or it's going to do really, really well. I was like, thanks, got it. Okay. I understand that those are the possibilities. But the fact that Paul's book was really widely read, well, so what she said, it really just depends whether people are willing to read a book that is about mortality by someone who recently died. And like, that is a little intimidating. But it was really interesting to see how many people picked up Paul's book and read it and passed it on. And so I think that's a recognition that, you know, people are thinking about this and perhaps eager, or at least willing to engage in thinking about it in a way that can help everybody.
Yeah, I mean, I mean, this is very true with, you know, being in medicine too, where the thing that you are working towards is sometimes like that ultimate goal that you see yourself in is something that's like decades down the line. And you almost feel like, well, as a medical student only, and I'm sure you felt this and probably you've experienced much more of this journey than I have, but it's almost like you're in this like tunnel and you're going straight and you're on one path and you're like, I need to do everything for this path. And I need to, you know, just check all the boxes that I need to check, that you almost forget that there are other parts of your life that are worth living as well. And I think what was one of the most beautiful things about this book is that it was a wonderful reminder that there's so many other parts of your life that you experience on the day to day that you don't appreciate as much when you are just striving for this like goal that you've kind of put in your head for your own future. And you just forget a little bit about your present. And yeah, for me, at least, that's what like really stood out to me and really stayed with me after reading this book. And I wonder if that's the same thing for other people as well.
Yeah, totally. And some of that's just practical, right? Like there's just literally so much to learn. Like you could study all day, every day. But at the same time, insofar as those other interests help you cope, or like bring your full self to answering these big questions that are looming behind every corner when you're studying medicine, I agree with you.
Yeah, so in our audience today, I think around half of them, maybe more, maybe I'd say half, are probably first-year students, and this is their first day of school. They've just had their first morning of lectures ever for, you know, med school, so it's probably a very big moment for them. And I'm sure they're feeling a little bit overwhelmed right now. I know I definitely felt very overwhelmed when I was in their shoes last year. So if you could tell your own medical school self anything, now that you know you've experienced what you've experienced, what would it be? And then also with that, what, you know, advice or comments do you have for our first years?
Yeah. So congratulations, first off, certainly. And I think medicine is so fun, and I would do it a million times again. And it's fun and fascinating and vulnerable and weird and full of power and interest. And I didn't feel every day like I would do it again and again, but I wish the same for you, that you feel that way. I think the main thing that I would tell my own self is purely, you are meant to be here. You deserve to be here. And I think, I don't know how many of you have heard of imposter syndrome. I'm sure some of you have. And I think, I wish I had known about imposter syndrome earlier, which is, I don't know like the actual definition of it, but it is what it sounds like, which is essentially a feeling that wherever you have arrived in your life is due to luck or chance or worth you actually being an imposter, like, oops, I'm going to get found out that I am the one person in my med school class where they made a mistake on picking me, and everybody else around here is so smart, and there's no way that I am like that, and this is terrible, I'm an imposter, I'm going to get found out. So I think that's the extreme version of it, but literally everybody in medicine either has it on the first day, or has it sometime, or has it before they figure out their strengths and what field is going to fit them the best, or even if they do, on the first day of internship, first day of residency, first day of being attending, et cetera. And I think one of the things that helped me, or that I found really beautiful, apart from just knowing what imposter syndrome even is, and then realizing that a bunch of people have it, is, I don't know how many people follow Mike Natter's work, but he's a person with type 1 diabetes and a cartoonist, an artist who is now an endocrinology fellow in New York City. So he's a physician too. And he wrote this essay in the Philadelphia Inquirer that essentially describes him telling one of his mentors that he has imposter syndrome. Like, I'm not supposed to be here, and I wish I didn't feel like that. And the mentor says, no, imposter syndrome is fine. You just have to allow it to anchor you without weighing you down. He says it's an anchor, not a weight. And that once you get away from the one end of things, which is imposter syndrome, you can tend toward hubris in a way that you shouldn't, or that's not good for your patients either. And so I kind of love that idea of having having that little bit of doubt be the thing that makes you better and makes you double check your work and makes you study really hard and acts as an anchor, not a weight. And I think, there's this sentence that Paul says at the end of the first part of When Breath Becomes Air and Being a Physician, where he says you can't ever reach perfection, but you can believe in an asymptote toward which you are ceaselessly striving. And I think that little space between you and the asymptote, is where imposter syndrome could fall, if you're lucky, So I think that's maybe the main thing that I would say, is that maybe you feel like that and you are meant to be here. You deserve to be here. And then the one other thing I would say is, I guess there's a lot, but one other thing I'll mention here, in case we don't get a time to talk about it later, is you've probably heard of burnout in medicine, which is, it's not a mental health diagnosis, although, during their training, you'll find people do experience mental health diagnoses, such as depression, anxiety, or others. But there's a phenomenon called burnout, which is even defined by the World Health Organization as an occupational syndrome. It's not a medical diagnosis, but it's a phenomenon of feeling three things: emotional exhaustion, depersonalization, and lack of efficacy. So it's like when you just get so overworked that you feel burned out. And I think you will find that there are some, so it used to be thought that when professional burnout was first being studied in medicine, which was only about 20 years ago, that we need to figure out a way to make physicians more resilient. Like, physicians need to meditate more, and physicians need to figure out how to cope better themselves. And then now there is a ton of research about medical culture and mental illness stigma and system factors like lack of flexibility or lack of professional connection, or unrealistic workload that contribute to physicians feeling burned out over time. And this is not to intimidate you, but it's like, the only reason that I want to say this is because if you find that you feel burned out, or that you are going through something like anxiety, the thing I would say to you is that it's not because something is wrong with you. And the culture around burnout and mental illness is changing a ton. And so the stigma is coming way down, and resources are really developing, and people are talking about it, and people are very open to connecting with each other over the hardships in the work we do, and learning to witness the things we do. And I think that sharing your own vulnerability in a way that builds intimacy and connection with your colleagues and even with your mentors is really important. And so I would say don't be afraid to be vulnerable, to ask for help, and certainly don't, it's easier said than done, but certainly don't feel like something is wrong with you if you are feeling like things are hard and you're struggling.
Yeah, thank you so much for that answer. I mean, yeah, it's definitely something we can all, remind ourselves by, once in a while, since it is, I feel like, you get lost in what you're doing and you forget that it's important to take time and step back and really just give yourself some time to relax. And then just like one more quick question, and this one is maybe a little bit more anecdotal, but there's this really great part of When Breath Becomes Air, where Paul talks about, his experience in the anatomy lab. And I was just wondering if you could give us a little bit more of, like a behind the scenes, or just talk a little bit about that particular section of the book. As I feel like anatomy lab is one of the most iconic parts of the first year of med school. So yeah.
Yeah. Wait, can I ask you, because I was talking about it with a friend this weekend, how are you guys doing anatomy lab during COVID? Like, are you doing anatomy lab but wearing a procedure mask, or how are you doing it?
So my understanding of it is that we are still doing anatomy lab in person. I'm sure there's probably some social distancing, things put in place, and people will be wearing masks. But for now, I think that will be one element of class that is in person. I don't know if Dr. Rifkin or anyone else wants to chime in on that right now, or if I got that mostly correct.
Great.
Okay. Yeah. So yeah. Oh yeah. She says.
Yeah. That's great, and it's also great that you'll get to be together. Period, as well. So that essay that Paul wrote, well, that section about the anatomy lab, funnily enough, in When Breath Becomes Air, was actually an essay that Paul wrote as a second-year med student that he later spliced into the book because it's so relevant. But when we were doing a welcome for the incoming first years, he had written that essay, and he didn't want to read it aloud. So I read it aloud in front of the first years. But he was obviously describing what he calls the reverse polarity of the anatomy lab, which is, he says, the CPR mannequins you pretend are real, and the donors in the anatomy lab, or the cadavers in the anatomy lab, you pretend are fake, ultimately. But I felt, I'm not even quite sure what to reflect on and say. I think Paul talks about how anatomy lab is part of a potential transition to a more removed, or worst case, callous professional, when you learn to treat a body in part as, matter and mechanism. But I found it really poignant at the same time, of course, and I still remember things like noticing tattoos or nail polish, or, Paul talks about how he found pills in the person's stomach. And I think that that sort of felt to me just like poetry in a way. It posed so many questions, like the main question, of course, being who was this person, which you sort of never get the answer to. Even if you could get every single detail about their life, you still wouldn't have the answer to that question. So I don't know. I found it like many things in medicine, and I think Paul describes this the same way, where there's the grand moral mission, and then there are the tiny details, and you keep like flipping back and forth between them at all times. So like being on hold with a patient's insurance company so that you can argue for them to get the medication that they need, that needs a prior authorization, is like a big pain in the butt, and also an act of love. So it's like, I feel like for me, I'm always zooming in and out between technical and like existential or love. And so anatomy lab was a lot like that for me. Yeah.
All right, so thank you again so much for your responses. They were all wonderful, and I took a lot out of that, and I hope everyone else did as well. So for this next part, I'm gonna hand it over to Divya. And if you have any questions, the Q&A box is still open, so please type them in and Divya will get to them. So thank you all so much, and I'll hand it over now.
Thanks, Sophia, and thank you again.
Thank you,
Dr.
Sophia.
Thank you again for being here to speak with us today. So I've been looking at the Q&A section and trying to see which questions are maybe relevant, and also touch on topics that maybe we didn't discuss in our earlier conversation. So I think I'll start with this first question from Emily Ho. So she asks, speaking of identity, could you speak a bit about your sense of identity and how it may have had to shift with Paul's diagnosis? For example, even the fact that you are speaking with us today about your experiences is extremely wrapped up in your husband's experience, his dreams, his memoir, etc. How did you hold on to your sense of self as a caregiver back then, and now as an advocate and voice for your husband's story?
Yeah, thanks for the question, Emily. Yeah, so obviously this was not what I thought I would be doing with my career or with part of my career. I think there's a couple ways that I will answer this question about identity. I'm trying to figure out which part to say first. I think in part, being a caregiver for Paul and then doing a book tour for Paul, which is what I did initially after Paul died and when this book came out, was very wrapped up in like loving Paul and doing something with Paul, for Paul, like carrying my own grief forward, like untangling my marriage to Paul while also carrying out this thing on his behalf, which has actually felt really helpful and sustaining in terms of grief. And in addition to that, like being able to talk about Paul or talk about Paul's writing, so often after somebody dies or after somebody goes through a really hard thing, they can feel emotionally isolated because other people are afraid to talk to them about it or afraid to ask them about it, like, oh, it's been a year since he died, so I guess that's over, she's fine now, or I don't want to ask her about it because I'm afraid I'm going to make her cry or whatever. And I think for me, on the grief, in terms of coping with grief, being able to do a book tour for Paul 9 months after he died was kind of perfect timing because I got to sort of keep his name and identity alive in a way that I really needed to while I was grieving. But I hear the question that you're asking, which is, how do you keep a sense of self doing that and through that? And I think, part of this is like related to my career in a way. So I think part of what I've learned in medicine, in academic medicine and medical practice on the day-to-day and the big picture is it's all about rising to the occasion of what you're being asked to do. And so whether it's like catching a baby who's being delivered and you've never done that before, or, taking care of a seriously ill patient in the ICU and telling their family that they're going to die, or going to anatomy lab shortly, it's all like, there's so many firsts and there's so many things that happen that are unexpected, and yet you have to do them right now because you're in medicine. And I think that in a way, the challenge of becoming a caregiver and figuring out how to do that, or the challenge of figuring out, like Paul used our family story, used his story to like contribute something to the world very intentionally. I feel like I'm doing a similar thing. Like if I didn't want to keep talking about Paul, like I wouldn't have to, and I wouldn't actually. I feel like I have a really strong sense, particularly now as a single mom and trying to practice medicine at the same time, of like what my actual boundaries are. And I think I really care in medicine about healthcare value, so healthcare costs, like financial costs, and like the human costs of healthcare and the decisions that we make. I really care about family caregivers. I really care about professional wellness and burnout for physicians. And I really care about end-of-life care and decision-making for seriously ill patients. And so it's kind of an amazing part of my career, actually, to be talking about Paul's book, but also like highlighting the parts of it that are also important to me. So in a way, I feel, I think this would actually be a lot harder to do in terms of my own identity if I were not a physician, sort of like contributing to it and using it in ways that I find meaningful in an ongoing way. And then I think being a family caregiver, or even just like being a physician, period, and holding on to your sense of identity does require sort of understanding who you are. Like, what are the things that really give me energy and help me relax? Or what are the things that I don't want to let fall by the wayside? Or like, I don't have time to see all my friends now, but like, who do I want to see when I do have time? I think, I don't know, it does require some self-knowledge about what will help you feel grounded as yourself. But yeah, I don't know. I think to me, my ability to feel my own sense of identity, I guess I would say like this actually feels like an anchor, not a weight, somehow, luckily.
Yeah.
Thanks
Yeah.
for the question.
Yeah, I think that's really wonderful. And I like how you kind of talk about how, like, because you are a physician, that you are able to, like, take a lot of the things that you learned and, like, these passions you've developed for, like, healthcare value, for empathy in medicine and all of these things, and actually apply it, like, in your career, in addition to these things you do, like, with the book.
Yeah.
Which is, I think, part of the reason why perhaps we also find this so resonant as a book, because it not only touches on, topics in medicine, but it also touches on topics that we can take back as, like, family members, as caregivers, as future patients, things that I think are very relevant to everyone, because everyone ends up living their life and dying at some point as well.
Right, or suffering in some way. Oh, and I also think story is really important, right? Like, we all know that. And if you like want to go visit your congressperson and advocate for something legislatively, even as a physician, the most effective way to do it is to go and tell a story about one of your patients, right? And then also to tell them some numbers and tell them, what you care about. But it really is about leading with the story. And so anyway, I think that's part of what seems useful and compelling about even above and beyond, like, loving Paul and getting to talk about Paul.
Yeah. So I've actually received a couple questions about this, but one thing that a lot of people seem to be asking about is, because you, like, kind of like we touched on, because you are a physician and you are someone who has gone through this process of suffering with someone who's had a terminal illness, do you have any advice for us as future physicians on what we should be doing when we see patients who have terminal illnesses or difficult diagnoses, and how we should be approaching those patients when we interact with them?
Yeah, so specifically, so I like the way that Paul talks in the book, and this was important for him in real life, about like trying to balance, he might phrase it as something like realism versus hope. I think that's the way a lot of people say it. I like what his doctor did about like really focusing on what was important to him. However, I really disagreed with what she did initially, at least about refusing to prognosticate, because I actually think that's a big part of what we do. And it is not possible to have a crystal ball and tell somebody exactly what's going to happen to them, of course. But one thing that is helpful is, I think when we learn statistics, we do have a sense of the median and the standard deviation, and we can kind of say either a range, like not the median survival is 11 months, but instead something like the likely range is a few months to a few years. Like, that is enough information to help somebody decide whether they might want to have a baby or not, right? Or go back to the work they're doing, or do whatever it is. Stop working completely right now, whatever they might want to do. And another way that I've had mentors teach me is to describe for someone the best case, the worst case, and the most likely case. And that's the same thing, right? Like putting some bounds on the probable. And then obviously it is such a human thing to hope. There's like essentially almost no way to extinguish hope. It is almost indestructible. I would hope, you know, that's like, I think that's good. So anyway, I think those are some of the things I would say. And I also think as you go along, you will get a lot of training in trying to get a sense of when people are ready to hear something, and are certain people in a family ready to hear something and other people aren't, and what kind of information might people need based on who they are. I think there's a chance that Paul's doctor acts really differently with other families where they know that the guy is not going home and looking up Kaplan-Meier curves on his own. That is a different thing, you know? So anyway, yeah, I think trying to figure out how to sum up what I said, but I appreciate the question, because I think, you know, when you enter medical school, you think I can come in with like many scientific tools and fix many people. But I think embedded in your question is there are things that we cannot fix. And so we're there as a guide and shepherd and a witness. And sometimes all we can do is witness, but it is very profound and helpful for people. Like that's part of the relationship.
Yeah, I think you put that really nicely. And I think for us who are still in the preclinical years, it is a bit reassuring to know that we will be learning this like as a process as we move forward, and that like the patients themselves will be kind of giving us feedback and allowing us to know like what they're ready for and what they're maybe not ready for yet. And so I think one thing that when we had our book clubs before this, and one thing we were kind of discussing in those book clubs was the fact that like as preclinical students, we're usually just seeing standardized patients and stuff. So it's hard for us to really get an understanding of what we should be doing. But I think that reading this book really helped bring some of that perspective to us and reminded us of like, you know, these things that we're learning affect real patients. And maybe we don't see that right now, but moving forward, we'll have a chance to see real patients. We'll be applying some of the things we learned. And of course, we'll be getting better along the way from like mentors and stuff like that too.
Totally. Yeah, like all throughout. And then when you're in attending, you'll still talk to your colleagues all the time. You know, like I was a little bit late signing on like right before 12:20 because I was talking through a case with a colleague who texted and was like, can I run this case? It's like, it never stops.
Right. Okay, so then another thing that a lot of people are asking about is the epilogue of the book, which I think was a very poignant reflection. And so one question was, in the epilogue, you mentioned how Dr. Paul Kalanithi was racing against time to finish his book. And at a certain point, he could no longer continue his work and that his book was unfinished. Past that point, was there anything more that he learned that you think he would have liked to have included? Do you think he found the answers that he was looking for?
So this is such a cool question. I don't think I've pondered it in a while. I think like what Paul really would have wanted was like to live to be 85. So I think like that's the thing that he would have wanted. He would have wanted to see Katie grow up. He would have wanted to be a neurosurgery attending. But I think in terms of like, was there something else big that he would have wanted to learn? I don't think so. I think he felt like he got his head around dying and like being a mortal being, which I think was like kind of the thing that he himself wanted to accomplish, and like really accepting that. And I think that he knew he did that and that really mattered to him. And since he died, I have since come across the way Viktor Frankl framed meaning in our lives, and I wish that I knew what Paul would have thought about this framing, because like one of Paul's friends after he died said, you know, I feel like Paul felt like the struggle to find meaning is the meaning. I'm not sure I totally agree with that, but it was very important to Paul to be a striver, to like keep getting better, whatever you were trying to do. But I also think that, so, okay, let me just say the Viktor Frankl thing and then I can relate it back to Paul. I've found this really meaningful. So Viktor Frankl, who was a neurologist, psychiatrist in Vienna, and was imprisoned at a concentration camp, and essentially all of his family died, and then he was freed and went on to have a medical practice and counseled many patients through various types of suffering, and ultimately developed sort of like a psychiatric philosophical construct called logotherapy, which essentially was just like a fancy word for meaning making. And so he's trying to help people make meaning or make sense of what was happening to them in their lives. And he ultimately formulated that. He said, meaning in life comes from three different things: work and love and suffering. And so work is like the things that you do or make or create, of course. Love, he talks about love for fellow human beings in relationships, like agape love, or just like love of humanity and human beings. And then also love and gratitude for other stuff, like a beautiful sunset or anything. And then suffering, he posited, was its own source of meaning, which is very strange and counterintuitive. And he essentially says that persisting through suffering is intrinsically meaningful, and making meaning out of suffering, or what some people would call post-traumatic growth, is also inherently meaningful. And that makes sense to me, you know, and I think it would have made sense to Paul. Is like suffering was not this like side thing on the side where the meaning in his life was actually coming from only these other sources, and suffering was totally meaningless and off to the side. I think the fact of, you know, like we really had to struggle to decide whether to have a baby. And as we were going through that process, and I said, I really think this is going to make things harder for you. Are you sure you want to do it? And Paul said, wouldn't it be great if it did make things harder for me? What Paul was essentially saying in posing that question was like, suffering is a measure of the size of meaning, right? And I think suffering is a measure of the size of justice. And suffering, you know, nobody decides to have a child because they think it's going to be easy, and nobody goes to medical school because they think it's going to be easy, and nobody like climbs up a literal mountain just to get to the top because they think it's going to be easy. And so I don't know, I think long answer, I do think that that is a piece of what Paul accomplished and wanted to accomplish. And I wish I could talk to him about that formulation, because I find it really helpful.
Yeah, I love that. I think that the quote you had was really great from the neurologist that you were talking about. And I think that one of my favorite lines from the book that you mentioned is like, wouldn't it be great if it did, is just such a beautiful summary of how like we do so many things, like you said, like pursue medicine, like try to, you know, do difficult things like having a child, or still pursue like difficult like relationships with our family or things like that. Like I think so many things that we do are centered around things that are difficult, but we find them difficult, yet we derive so much meaning from them. I think that's really beautiful.
Yeah.
So it looks like we have time for one more question. So I'll ask that. And I'll just invite all of the medical students who are listening to come to the reception later at 2 p.m. We might start a little bit later in case you need a break, Dr. Kalanithi. But, and you guys can ask your questions there in case they didn't get answered here. But one final question was just that, you know, your daughter is so young, but this story that that has been told is so widely known. And so some of the students were just wondering whether if she knows about it, and if you plan on ever sharing this memoir with her and talking about it.
Yeah, thanks for asking. So yeah, she's a first grader. Right now she can sort of like recognize Paul's book. She would just say like Daddy's book, but doesn't really know about it. she certainly knows about him, obviously. And I think I try to talk about him and kind of insert him into things. And like I even fell in love after Paul died. And at the same time, he is her dad. Like he's her dad, and she's his kid. And I expect that she'll have a relationship with him over time, unless she doesn't want to, but she'll figure that out. And so she knows that they both like to take hot showers, and they both love dogs and reading, and he was funny and she's funny. And it's like, you know, she knows a lot of stuff about him. And she knows we go to his grave, and she knows that as a place that's just like, maybe she's going to see a bunny. And but she also is sort of like learning, she certainly knows now that that's a monument to Paul, you know, like the headstone's a monument to Paul. But I try to choose my words really carefully, which also teaches me something about like acceptance and framing. So I'm just trying to think of an example. I'll give an example. So like the last day that Paul was alive, when he was at the hospital, she sort of knows that story now, because I think on the anniversary of his dying or something, I think I told it to her, but she knows it in a different way that sort of centers her, which is, you know, I said, Daddy, the last day that Daddy was here, he only wanted one thing. Do you want to know what it was? And she's like, to see baby Katie. And it's like, yeah. And then she kind of knows that, you know, a baby's not allowed into the ICU. And so the nurses had to do this whole special arrangement to let her come, which was really special in a form of like high quality healthcare, in my opinion, to let the baby into the ICU. But she understands it as Daddy wanted to see baby Katie, and baby Katie got a special rule to go inside the hospital. And so it's like she knows all of this kind of stuff that essentially like our family lore is for real, but it's in this like childhood language that she'll grow up into later. And like I've made her a little picture book about Paul that describes him growing up and describes some similarities, and has pictures of his gravesite, and then has pictures of the rest of our family. And I ran the language past the child life services folks at the hospital, because there is a way to talk with children about difficult things, you know, in words that you know, ultimately we're trained to use with kids. And so, but at the same time, the way that she just sort of like lives her life and accepts the way that our family structure is now, and all of it is also like really a lesson to me.
Yeah, that's really, really beautiful. I think that I think we can all, like, you know, think about you know, how we talk about someone after they've passed, both like, you know, with our, like, to ourselves and also to our family members, and of course to children who have a very different way of perceiving the world than we do. And I think that you bring up like, you know, a really interesting point in that, like, children process things differently, but they still really value having those connections to the people in our past. And I think that's really beautiful that you've made this book for her, and that you're able to keep the memory alive as well. So I think that should be it for our questions today. And for anyone who had other questions, because there were so many really good ones, I'll ask that they ask it in the reception later on. So just to conclude, I just have a little statement to say. So I would like to thank you so much, Dr. Kalanithi, for coming here and taking the time to speak to us today here at UCSD. I think I speak on behalf of all of us listening that we thoroughly enjoyed reading the book, and along with what we've spoken about today, it's really reminded us of what it means to live a meaningful life and what truly matters to us and our patients as we go through this long and often very challenging journey towards becoming physicians. And to everyone who's a first-year medical student who's listening, like I said earlier, you can come to the reception at 2, and then if you have any thoughts, please feel free to write those on the Kudo board that we have posted. And I would also like to thank all the people who made this event possible, So our classmates in the first lecture committee, which are Sophia, who helped host this event, as well as Kylie, Allison, Sid, Victoria, Aaron, and Sumana, as well as Ariana and Burton from the Student Affairs Office, and our faculty mentors, Dr. Dina Rifkin and Dr. Marty Stein. And for any first-year students interested in serving on the first lecture committee in the future, we'll be sending out details about that later in the year, so please look out for that. And so just to wrap up, thank you again so much, Dr. Kalanithi, for joining us today, and wishing everyone who's listening a very lovely start to the school year.
Congratulations. Thank you.
Thank you.